PowerPoint. But that PowerPoint is integrated in with this one too, so you'll see it two different ways. But it's all the same stuff, so don't get confused with that. Apparently I gotta put a study guide out, is what Josh said, so. I have one that's not as in-depth as the one that Dr. Carter put out, so I'll put that out there. It's real basics. A lot of tonight's content is gonna be kind of a review, but we're gonna go a little more in-depth with that review. So you should know kind of an idea or a basic idea, guideline of what we're talking about tonight. Like I said, we're just gonna go a little bit more in-depth. Questions about anything? Everybody have a good weekend? Good Labor Day? Everybody labored? I labored. I wrote a paper. Ate a bunch of cocktail weenies on Saturday. That was great. War Eagle, everybody. War Eagle. Go Knowles. That's a great weekend. All right, perfusion part 2. Perfusion part 2. First little section is going to be basic EKG review, a couple advanced EKGs in there as well. We'll put that in there. And then we'll get into more of the perfusion part 2 type stuff. So we're going to talk about rheumatic endocarditis, some more shock, basically a brief overview or a little more in-depth overview than what we covered last semester. And then we'll also talk about valve disorders as well and how that's going to alter our perfusion, how that's going to affect the flow of blood or the circulation of blood throughout our heart, and how it alters that perfusion to our vital organs and to some of our fingers, hands, toes, that kind of stuff as well. Basic EKG review. So when we're going to review an EKG or interpret a rhythm, we have basically 8 steps to figure out sort of what's happening with that heart, how to interpret that EKG. So first, rate. Pretty self-explanatory, right? How fast is that heart beating? How are we going to calculate this? Count what? 6-second strip of the QRS complex is what I heard. I like that. All right. We know how fast it is. So let's say, what would normal sinus be? How fast? 60 to 100. Good. What about sinus tach? Below 150, but above 100. So 100 to 150, right? All right. And then anything above that 150 mark is going to be considered SVT, supraventricular tachycardia. After we've established the rate and we've kind of decided if it's going to be in one of those 3 categories, next we're going to look at the rhythm. Is it regular or is it irregular? It can be either one of 2 options, regular or irregular. How do we determine that? I like measuring what, Meredith? The distance of what? QRS complex to QRS complex, right? So those nice tall mountain peaks that we see on the QRS complex, if they're regularly spaced, that's going to be that regular. But one's a little bit shorter, one's a little bit wider. They're inconsistently spaced. That's how we're going to determine if it's irregular or not. Our P wave. What's our P wave?
The atrial contraction.
Atrial contraction. Good. All right. Do we have a P wave or not? If we don't have a P wave, that's going to tell us to go a certain route on that EKG interpretation. Maybe we can start thinking about certain rhythms. Our PR interval, what is that? Good, so just between the P wave and then that R on that QRS complex. How long should a PR interval be?
0.12.
I heard what?
3 to 5 boxes.
3 to 5 boxes. Okay, good. Which is what? 0.12 to 2. Good. Or 3 to 5 boxes, as Chuck says. Yeah. Okay. QRS complex. What does that mean for us? What's our heart doing?
It's the ventricular contraction.
Ventricular contraction. Good. Perfect. ST segment. What is that? between the S wave and the T wave, right? The ST segment, that little space. Why do I care about the ST segment?
It'll tell you if you're having a STEMI or a non-STEMI.
A STEMI or a non-STEMI? Okay, get more specific. So
Okay,
STEMI is gonna be what?
A STEMI is gonna be ST elevation.
ST elevation, all right? So that little ST segment, if it's raised above that isoelectric line, so kind of that middle place of that EKG rhythm, it could signal maybe we have some type of heart damage that's actively occurring. So that's STEMI. So new onset of some type of heart injury, right? Versus a non-STEMI.
Which is depression or inverted T wave.
Okay? So that little ST segment, it may go just below that isoelectric line, or it may not be changed at all. We could also have that T wave flipped over, and this could mean old ischemia. So some type of old heart injury that has occurred at some point or another. And we'll see that represented on our EKG. All right, number 7, T wave. What's our T wave?
The relaxation of the ventricles.
Relaxation of the ventricles.
No.
I like the ventricle relaxation. Good. Perfect.
Not wrong.
All right, ventricular relaxation. What kind of things can alter my T wave? Aren't there some things that make my T wave look weird or
Oh,
funky?
electrolytes.
Electrolyte imbalances, all right. What's one good electrolyte that's gonna mess up my T wave?
Mag.
Mag, all right, what else? Potassium. So if I have a high potassium, I can have a super high T wave, right? It's gonna be a very big T wave. It might even match the QRS complex, it gets so big. And then we have to worry about those electrolyte abnormalities and how that's gonna affect our EKG overall. Maybe turn us into some type of lethal rhythm. So high potassium, high peaked T wave. Lastly, that QT interval. So the QRS complex to that T wave, how long does it take my ventricle to go through its complete cycle? So the beating and then the relaxation of that ventricle. So that kind of whole cycle right there. So everybody's been asking me, what is that big number on the side of the EKG or the side of the vital signs monitor, the heart monitor at the bedside? And it says like 390 or like 450, something like that. That's our QT interval. So anywhere from 390 to about 450 milliseconds. So about 10 boxes, give or take. That's that big QT interval that you'll see on the side. So next time you go into ICU or you go up on the progressive, they're gonna have those bedside monitors and you'll see it. It says about in that 400 range, or that's where we want it to be, at least. Big things to note here, I would probably know this for sure, that EKG paper. Small squares are to 0.04. Big squares, 0.2 or 5 of those smaller squares. So when I'm counting and I say, oh, the PR interval is 5 small squares, I know that's 0.2. That's my PR interval. That's how I measure that. So we should be able to know how long that is, not just small boxes or big boxes. What's the actual seconds involved with that? Okay. Questions about EKG interpretation? Another good example, it really breaks down what we just talked about on the previous slide, and it actually puts it on an EKG rhythm strip. You also have your measurements right here on the far end as well, has a small little box at 0.04, and the bigger box, which is the 5, for 0.2 seconds as well. And then you can actually calculate and count these boxes to know your normal ranges for your different sections of your EKG to determine that EKG interpretation. These may be just a touch off, but know your normals for that, all right? So let's review a few EKG strips or rhythms. So when I call on you, don't everybody blurt it out at once. Let's talk about what it is. How did you get there? So why is it, I don't know, second degree type 1? Tell me why. What type of causes can occur? How are we getting to this point? What's our body doing to make us go into that rhythm? Maybe some signs and symptoms of that heart rhythm. What is my patient going to present like? What are they, that physical assessment, what are they going to look like? And if treatment, if at all any treatment, what are we going to do for them? Okay? All right, Drew, what do we got?
Asystole.
Asystole, okay. What type of signs and symptoms we're gonna have?
No, it's lack of signs.
Lack of signs and symptoms, all right. How do we know it's asystole?
Flatline.
It's flatline, okay. Do I know it's asystole by just looking at this?
You can check for pulse.
Check for a pulse, that's my most important thing, right? I need to assess my patient. I know more than this monitor does right here, right? Assess that patient first. Maybe they hopped out of the bed and all the leads fell off, and now I can't accurately get that heart rhythm. So they're alive. They can't be an asystole because they're still alive, moving around the bed. They just ripped off their heart leads. So check that pulse first. Assess your patient. Make sure this really is asystole. How long are we gonna check a pulse for if they're not responsive?
A minute.
A minute?
No.
Man, your patient's gonna be dead for a long time.
15 seconds.
15 seconds, your patient's still dead for a while. 10 seconds, I like 10 seconds. Less than 10 seconds. And then Drew, what are we gonna do?
Hit the code blue button.
Hit the code blue button and then what?
Start CPR.
Start CPR, right? Good. Once everybody starts running in, we're gonna do that ACLS protocol. So there's a left side and a right side to that ACLS protocol. We have the asystole and the PEA side, and then we have the VTAC VFib side. So this is gonna fit under that asystole side, right? With that, big things. Start CPR. You can't shock asystole. There's no electrical conduction that's happening here. If you shock it, there's no point. Some physicians will say this is a very fine VFib. They are lying to you. There's no such thing. They just shock them anyway. That's kind of that last ditch effort. This is just asystole. Compressions and epinephrine are gonna be the two big things. Epinephrine, that 1 amp, every 3 to 5 minutes. We're gonna do those compressions to 100, 120 beats per minute for 2 minutes. That's gonna be that 5 cycles there. Once they get that airway in, we can give a breath to them every 6 seconds. But all this is happening at one time. I'm not gonna test you on the ACLS protocol, but just good things to know in the back of your mind. Good job, Drew. What else we got? Chuck, what's this one? AFib, all right. Tell me about AFib.
Lack of a P.
Lack of a P, all right, good. What else?
Irregular.
It's irregular. How do we know it's irregular?
QRS distance from peak to peak is off.
All right, good. So everybody see this spacing to this spacing is a lot different than this spacing to this spacing? Okay, perfect. What's our rate on this, Chuck? 90, good. He counted the QRS complexes, perfect. What are my signs and symptoms gonna be? What is my patient gonna look like, Chuck?
Can be most likely asymptomatic.
Okay, so people can just walk around this every day and not actually know it. What if they are symptomatic?
Shortness of breath.
Shortness of breath, okay, good. Weakness, fatigue. All right. What's one of our biggest complications with AFib?
You have coagulation in the atrium.
All right, good. So clots in the atrium. That's what I'm most worried about with AFib. Can also have a decreased cardiac output because the atrium are not beating efficiently like they should, so not pushing that blood further downstream, if you will. And so my body is not getting the demand that it needs, the adequate blood supply that it needs. So decreased cardiac output, which is gonna also hurt our blood pressure, our vital signs, that kind of stuff. If we let this AFib go on too long, we could also start getting into those heart failure complications as well. How are we gonna treat this, Chuck?
Amiodarone.
Amiodarone, good. So antiarrhythmic, what else?
You also can synchronize cardioversion if that doesn't work.
Okay. So let's talk about synchronized cardioversion for a minute. So sync means that I gotta sync it up to those QRS complexes, which means my patient has to have a pulse before I do this. If the patient has a pulse, we must synchronize cardioversion. All right. But before we shock a person in AFib, what do we need to know about them? Anybody?
If they're DNR.
If they're DNR, well, I guess that could help.
Like for the clots, you have to do some kind of test?
Gotta do some kind of test for the clots, right? So they have clots. We send them back into a normal rhythm. Where are the clots gonna go?
The lungs.
Who knows, lungs, it go into the, maybe the coronary arteries, or we could give our patient a stroke. So we gotta figure out if they have clots or not. So there's some type of test called a TEE, transesophageal echo, that we can perform. So we put a scope down their esophagus, and we kind of look at the other side of the heart, and we actually can look inside the atriums and make sure we don't have any clots. If they do, we're gonna be on some anticoagulants for a little while, and then we can potentially get them out of that AFib rhythm. Some people never get out of AFib, and that's just the way they are. And we'll put them on anticoagulants, maybe put a filter in just to catch any excess clots that may form and may want to go further downstream, okay? Questions about AFib? All right, Zach, what we got?
That's a dual paced rhythm.
Dual pace rhythm. Perfect, how do you know that?
Because you got two pacemaker spikes in between each QRS complex, or well, one before the P wave and one before the QRS wave.
Perfect. So another name for dual pace is going to be AV pace, atrial ventricular pace. And like Zach said, so we have a pacer spike right here, then we have a P wave. Remember, our P wave is that atrium contracting or beating, and so that pacer spike, that pacemaker is firing to make sure my atrium is going to beat like it should. And then I have another pacer spike right after my P wave, but right before this QRS complex right here. Remember, that QRS complex is that ventricle beating. So that pacemaker has to fire to make that ventricle beat. So we have that AV paced or dual paced rhythm. Anything we need to know about pacemakers, Zach?
There's limitations on what they can be exposed to as far as like microwave or MRI, something like that.
Good.
And then make sure you change the battery.
Make sure we change the battery. Yeah, that's important. Because if it starts to fail, then their heart rate could drop all of a sudden, right? Might start having these syncopal type episodes. So we get things like failure to capture, where our pacemaker is not able to read the exact part that it needs to fire at, and it starts to fire all over the place, or it doesn't fire at all. And so we get those crazy type rhythms. Yes?
Do pacemakers respond to demand at all, or is it just like a set rate?
They will respond to demand. There's certain ones, certain manufacturers that will. And there's also some that has a defibrillator setting as well, an AICD as well. And if it detects a certain lethal rhythm, and you can set this, or if it detects, let's say 10 PVCs in a row, it will shock the patient and hopefully get them back out of that lethal rhythm. Pretty cool when you see these in use. I don't know if it's cool or not, but it's interesting to know. When you're doing compressions on somebody that has an AICD, it will fire. It's not going to shock you, but you're doing compressions as the patient is getting shocked. So it's very odd and weird, but it does happen, but it will not shock you. So. Questions about pacemakers? So what if I only have a pacer spike before the P wave? That's just what? Atrial pace, right? What if I have it just before the QRS complex? Ventricular comp. Yep, perfect. Who's next on the list? I like Haley's name. Haley, tell me about this one.
A flutter,
A flutter. I like a flutter. Good. How can you tell?
sawtooth pattern,
That sawtooth pattern, good. How else can you tell? Why is this not AFib?
it's regular.
It's regular, right? Good. So, with the atrial flutter, have that sawtooth pattern. That's that classic appearance. But she also said that the QRS complexes are regular. So they have equal spacing in between each. So your classic sign there for atrial flutter. AFib is going to have that very irregular type of spacing. What kind of complications can I see? What am I worried about most? Anything that's messing with my atrium.
It's gonna be clots.
Still big clots, yeah, good. So we gotta worry about clotting. So I gotta talk to them about anticoagulants before I shock them out of this rhythm. Make sure I don't have any clots within that atrium. That atrium is still quivering. It's just a little more regular.
You do a TEE,
Yeah, you can. Sometimes they'll just do a adrenal echo too. Transesophageal echo is better. Any questions about A-flutter? Who's next on the list? Jess is next on the list. What we got?
Is that normal sinus?
Close. What's our PR interval tell us? What do you think? Okay. So we have, let's see, 1, 2, 3, 4, 5, 6. So it's 6 QRS complexes. Rate's gonna be 60, right?
Mm-hmm.
We have a P wave, don't we?
Yes.
We have a QRS complex, right?
Mm-hmm.
And then we have a T wave. Right, so we have all our parts and pieces, right? Is our QRS complexes regular? Regular spacing. Very regular spacing. So let's look at our PR interval. Very hard to tell in here, but it's pretty prolonged, right?
Is it a first degree?
It is a first degree, good. So we have a very prolonged PR interval. Is our PR interval getting longer and longer and longer, or is it consistently prolonged? It's consistently prolonged, right? It's not changing up. That's gonna make a little more sense when we talk about a different type of rhythm in a little bit. Are we dropping a QRS complex on this, Jess?
No.
We're not losing anything. So if we're not losing anything and we just have that prolonged PR interval, that's gonna be that first degree AV block right there. Does that make sense to everybody? First degree, prolonged PR interval, but we don't drop a beat. Remember what our normal PR interval is. Anybody? 0.12 to 0.2, right? 3 to 5 boxes, right? Do we need to do anything about this, Jess?
No, not unless there's something wrong with it.
Right, yeah. Patients can live with this, right? It's not too bad of a rhythm. Could progress further though. What if we start dropping complexes? We might need to know something about that. Might do something about this. But overall, this is okay, right? Okay. Megan, what we got here?
Let's see.
No idea. Alright. Let's talk about it then. What's our rate? 60, right? Sort of, kinda. Alright. Do we have all the parts of our EKG that we need? So do we have a P wave?
Yes.
Okay. We do, right? Do we have a QRS complex?
Sometimes.
Sometimes, okay, good. That might come and play in a little bit. Do we have a T wave? So for the most part, we have all the parts we need for a heartbeat, right? Is it regular or irregular? So do we have equal spacing between our QRS complexes? Mostly we do. So from here to here and then here to here, we have it. Okay. So it's pretty regular, not so fast. But what are these big ugly looking things right here in the middle? Those are PVCs, right?
Well, I thought that was decent. I didn't know they did look. I thought they all.
So premature ventricular complex, do I know?
By PVC, because there's two different ones.
Oh, we're on the right track. It's not called bi.
Multifocal.
I'm hearing multifocal. Yes, multifocal PVCs, all right?
I didn't know they did look. I thought that was.
That's fine, that's perfect.
That's all.
So that's why we're here. Normal sinus rhythm, because we have everything that's regular, normal rate. But we have multifocal because our PVC is going up, and then we have one that's going down, right? we have unifocal, all our PVCs are gonna go in that same direction. Yes, Meredith?
I don't understand how that's regular.
So the PVC is gonna throw it off a little bit, but it goes back to that regular rate right here.
But it's not.
It's a little bit wider, I guess.
Second QRS.
What now?
There's a huge space between the first and second QRS.
This should be a QRS, but our ventricle took a break, if you
But
will.
even if it was, that's still not in the middle of this year.
Right, but it's taking a break and it's also a little bit early. But for the most part, it is regular. It's hard to get past, I know. But if you look at the normal section of this heart rhythm, for the most part, it's regular. Anything we need to do about this, Megan? Is it okay to have a lot of PVCs?
No, not a lot in a row.
Not a lot in a row, or what if we just have them all the time, but not necessarily in a row? Is that still okay? Why not? Your heart's not doing what it's supposed to, right? Are we perfusing with these beats right here? No. So that blood is not pushing forward like it should. Perfusing those vital organs like we should. So this is some type of arrhythmia, right? Some type of abnormal type of rhythm. So what things can cause this? Things like electrolyte imbalances. Caffeine can do it. Not taking your medicine appropriately. Alcohol. Stress, anxiety, nursing school. Those types of things. Hypoxia, if I didn't mention that one, that's a big one. So what am I gonna do about this then? So with those causes, how do I treat those causes? So for hypoxia, what am I gonna do? Give them some oxygen, right? Hopefully that'll fix it. All right. What about electrolyte imbalances? Do it one way or the other, right? If it's too low, give them more. If it's too high, make them get rid of it. However that may be. So if there's high potassium, for instance, maybe we can give them a little bit of K-exolate. Maybe some insulin and D50. If they don't respond to that, we could probably get them on dialysis if we just had to. Can also give them some medications, right? So we can get some antiarrhythmics because they are trying to go into that lethal rhythm. They are having some dysrhythmias. So I can give things like amiodarone, right? And lidocaine. Lidocaine's an old drug, but it's still used out there some. Depending on what hospital you work at too, they'll give you lidocaine a lot more. Usually we're gonna go amiodarone or like a digoxin. Digoxin's getting kind of old too, but for the most part, amiodarone. I would probably know how to treat this if I were you, okay? Questions about normal sinus rhythm with PVCs? Multifocal PVCs, sorry.
So it's just called PVCs if they're all the same?
Yep.
Quadgemini?
No such thing.
That's it.
That's just frequent PVCs. You got bigemini and you have trigemini. I like where your head's at, but yes. Technically it is every fourth beat, but there's no such thing as quadgemini. Alright. I think, a couple slides, I've got one that's a little bit different. We'll talk about bigemini and trigemini.
How many is considered to be that?
5 or more, but if you call a physician for 5, run beat of VTAC, they're gonna yell at you, so take that with what you think. Cardiologist is gonna be real mad, so they just don't really care. 5 beats, whatever. And you should know what to do already too, especially if you work in those critical care settings or even not in the critical care settings. I know I need to check my electrolytes, so maybe I go ahead and draw my morning labs a little bit early. Or maybe I put an order in for electrolyte panel, go ahead and get that on board. Make sure I get a 12 lead EKG. Just because it shows up like this on that bedside monitor, let's make sure that EKG confirms that. That 12 lead EKG is also gonna do some interpretation for me as well. And the physician's gonna want that beforehand. He's gonna want a current set of vital signs to make sure there's nothing off with that as well. So you'll kind of have all these things already ready to go. And then you can call him and say, hey, this is what I got. All right, who we got? Meredith. What I got here? Okay. Maybe,
And,
let's say the QRS complex is perfectly fat, it's not skinny.
okay, I'm really bad at these. It's got a regular rate, it's got a regular rhythm, it's got a P, it's got a QRS, it's got a T.
Okay, how fast is it?
Um,
What's my will?
80.
80, okay. So what does that mean then? If everything's normal,
Oh, it's fine,
normal sinus rhythm, right?
Oh,
Okay, perfect. So, everything's normal in this. Does that make sense to everybody? Got a P wave, got a QRS, got a T wave.
but isn't the QRS supposed to be at least 3 boxes?
It's 390 to Bosky T interval. Yes, at least 3 boxes on the QRS complex. And maybe like 2.5. So it's a little skinny, but it's normal size. Don't read into it too much. I am not going to confuse you that much on the
So
exam.
too skinny is normal and irregular is regular.
All right, moving on with that. What do we got next? Anna, what we got here?
A second degree Winky Bach.
Second degree Winky Bach.
Wait a minute. No, it's technically, it's a Mobitz.
What's
Two.
what?
Just a regular second degree Mobitz to not a Winky Bach, because the per-yard interval is not, doesn't prolong.
Okay.
It's not longer, and longer, and then
So
you're off.
second degree type 2 or Mobitz 2. I like it. So she was talking about the PR interval. That's how I know this one is a little bit different. So your PR interval right here, what's our normal?
0.12 to 2.
0.1 to 0.2, 0.12 to 0.2, okay? Is this PR interval getting longer? Or is it consistent?
Pretty consistent.
Pretty consistent, right? For the most part. Meredith, you agree?
I agree.
She agrees with that one. All right, perfect. Moving on. So, and then we have a P wave, but then do we have a QRS complex with that P wave?
No.
We don't, right? So I'm dropping a beat. That's how it's gonna differ from that first degree AV block. Remember, in first degree AV block, we have that prolonged PR interval, but we don't drop that QRS complex. That consistent PR interval, but do not drop the QRN complex. Here, we have that persistent PR interval, but then we drop a complex. That makes sense. Perfect. Also, look at our T wave. It's kind of high, right? What did I say about high T wave?
Potassium.
Potassium, right?
I mean, the basis of most cardiac arrhythmias.
Exactly. Are we gonna do anything about this, Sam?
I mean, if you leave, usually if you, what is it, if you leave it alone, it could progress into third degree,
It could.
and so it's not amiodarone.
Really, amiodarone is not gonna be the best option for it, but really we're gonna treat that underlying cause, whatever that may be, okay? Questions about second degree type 2?
Is this one you can give atropine to, is, or no, maybe not?
Can, but not.
Which one's the one that you
It's
give
not gonna help a
atropine
whole
to?
lot. Third degree heart block is gonna be the one that you really don't need to give atropine to, and it's not gonna help at all with that.
So basic underlying cause for these is,
It could be things like hypoxia or a P, maybe a previous MI injury, and so it's messing up somewhere in part of that. Also the nodes, some electrical conductivity, some type of conduction failure of some sort with that. And I'm not gonna let you have to memorize that at all. It's something with the electricity part of the heart. It's gonna
Okay.
help it. Who's next? Stephanie. What we got?
Sinus Brady,
Sinus Brady. How do you know that?
because it's very slow, but I mean, it looks irregular, I mean, it looks regular.
Looks regular, right? This is very slow. What's my heart rate?
Yours is cutting off the first one, but on my screen it's showing 4, so we go with 40.
Okay, perfect. Works for me. Is there? Yeah, there is another QRS complex. I'm not sure why it's cutting off on here, but There should be another one on there somewhere. 40 is our heart rate. So remember our normal was what, 60 to 100? So anything below that 60 is gonna be considered sinus Brady. I have a P wave, I have a QRS, and I have a T wave. So I have everything that makes an EKG an EKG. It's regular. My spacing for my QRS complexes is regular. So I have everything that I need, it's just real slow. So 40 beats per minute. Is this okay?
No. I mean, if you're
Stephanie,
an
what do you think?
athlete,
If you're
If you're an athlete.
If you're an
But
athlete,
if you're
right?
a lady, probably not.
So me, like me, I'm a prime athlete. I can run a 40-yard dash at 4.1.
I'm not too worried about you unless.
And
you're
so I'm not
diabetic.
worried about it because I'm having that consistent cardiovascular exercise. I've trained my heart to beat this low, and I'm not symptomatic from it. But what if I am symptomatic for it? Then is it a problem?
Yeah.
Okay, what am I gonna do about it?
We're gonna give medications, which, now
kind?
that you're asking me, it's slipping my mind,
Atropine.
Atropine, right?
Yeah.
Okay. Atropine's gonna be key, something for sinus Brady. The big difference with atropine is gonna be that they have a pulse. Yes, I can give epi. That's gonna help out too. But usually reserve that epi for no pulse. First gonna try atropine to see what happens. What if atropine doesn't work? What could I do?
Just call it.
Just call it.
yeah.
Meredith is gonna work in the morgue, it sounds like. That's what type of nursing she wants to do.
I mean, hospice nursing is a thing.
Hospice nursing.
Uh,
Pace,
Pace.
right? Alright, Sam, talk to me about pacing though, since you talked about it. What about pacing? What kind of pacing? Transcutaneous, so we're gonna put those defib pads on, right? Make sure we set it to the correct rate. Make sure we set it to that correct milliamp. You're the only one that hasn't heard this discussion yet, so that might also be part of the problem. I just thought about that. I've talked to everybody else about pacing through the Zoll monitor, but.
You're the one that set the clinical schedule.
What would you set it to? Like, what, would you just set it to 80 in the middle?
I usually set it like 160 because I want my patient up and moving real fast. No. Usually we're gonna get a baseline about 70 to 80. We're gonna start with that, and then we're gonna crank up that milliamp very slowly. I want just enough electrical current, basically enough shock to shock their rhythm or shock their heart rather, to zap them just enough to get them to that heart rate that I want. Very temporary that we do transcutaneous pacing. Your patients are not gonna go home on this, all right? They're not just gonna put that defibrillator around all day, all right? This is to get them to the cath lab, get them to Dr. McCarty so she can do her thing in the cath lab, all right? So they can put in more of a permanent type of pacemaker. So we get them, we turn that milliamp up, we get them to that 70-ish range for their heart rate. Then we can see what their vital signs look like. So if they were symptomatic before, their blood pressure was taking a hit because they didn't have enough cardiac output, and now that I crank their heart rate up, is my blood pressure rising? Are they symptomatic? Are they dizzy? Are they short of breath? Are they fatigued? Those types of things. And if it's enough for them, then I can stay at that 70 heart rate. But if I need a little more oomph out of it, I need a little more blood pressure, I need a little more cardiac output, then maybe I can crank it up just a little bit to like 80. This is a very slow process, guys. We're not going from 70 to 150 and just cranking that thing up. We're not shocking that heart like that. All right. Questions about sinus Brady? No. Okay. Sam, tell me about this one. I heard a winky bot. Good. So second degree type 1 or Mobitz 1. How do you know that? Longer drop. All right. What's longer and longering? PR interval. Good. So we start over here on this far left side. PR interval looks pretty normal right here. And then it's getting a little bit longer. And then again a little bit longer. Then we have a P wave, but no QRS complex. So we have dropped that beat at the end there. That's what's gonna make it different from that second degree type 2, is that the PR interval is getting longer and longer. You okay? You good? Okay. Second degree type 1, different than that second degree type 2, that longer PR interval. And eventually we have that drop. Anything we need to do about this now?
There's no symptoms, you just monitor the symptoms you can measure.
Okay, we could do that. Good. Right. Have I talked to Hannah yet? I haven't talked to her yet. Hannah, what's this one? Sinus tac, how you doing?
It's above 100 beats.
It's above 100 beats. How many beats above?
It's 30 above.
130, yeah, okay, good. 130 above. So it's 130 is our heart rates. So she counted these QRS complexes right here and got 130. Things get pretty jumbled up pretty fast, so don't go a different route. So like your T wave and your P wave, they're getting pretty close together because that heart is beating so fast. So don't misinterpret this for something else. A lot of times I would highly recommend getting that rhythm strip, printing it out, and looking at a still version of this. Make it a lot easier until you start interpreting these a whole lot more, so you can understand what these look like. Get that 12 lead EKG. Make sure this isn't some other funky looking rhythm. Make sure this is a sinus tac. All right, Hannah, what can cause this kind of stuff?
Stimulants, caffeine.
Stimulants, caffeine, okay, good. What else?
Anxiety.
Anxiety. What about something in the body?
Like infection.
Infection, good. So maybe something like a fever. Okay. What about a pulmonary embolism? Yeah, problem. What about hypotension? Yeah, it's going to cause hypotension, but hypotension can also cause this because my heart rate's trying to compensate. Heart rate's trying to get up a little higher so I can boost up that blood pressure a little bit. So what am I going to do with this?
Treat the underlying cause.
Treat the underlying cause, okay. Initially, is there anything else I can do? How am I going to slow this thing down? Any kind of medications I could give? What about those LOLs?
Yes,
Get some beta blockers, right? All right. What's your favorite beta blocker?
one I don't say right.
Good. That's the correct way to say it. Good. I like it. So, what did my patients say a while back? Metapawpaw, or metropolol. That's how I say it. However you want to say it, it's fine. So something like a beta blocker. Maybe some oxygen too. Maybe they're a little bit hypoxic. So just go ahead and throw 2 liters on them. That's not gonna hurt nothing, right? All right.
Could you give adenosine?
Did you give it adenosine? I don't know. You tell me.
Well, I thought that slowed down SVT.
It will. So adenosine is going to be a little too aggressive for these type of rhythms. Yes, it will slow it down and it will reboot it, hopefully. But we usually don't give adenosine for a sinus tac. Usually we can control it with something like that beta blocker, or give them a little bit of oxygen. If they have a fever, give them that Tylenol that's ordered. Give them those antibiotics, letting the infection run its course.
Could you vagal on this one?
You can vagal respond, you could.
Is that effective?
Sure. No, I've never seen it happen before. I'm gonna be honest, I don't know if I've ever told my patient to vagal. It just happens. We teach you that, and it does happen. It does, but we don't usually go for vagal response. Vagal response really, it's not for emergency type situations either. So if they're in this really symptomatic SVT, I don't really care if they're vagal. I'm gonna do something a little bit quicker response from there. Questions about sinus tac? Josh?
I was hoping I
I
wouldn't.
know, cause I'm studying, this. I think it's a secondary type one.
No.
Yeah, I don't know.
Is it some type of heart block?
I'm gonna be completely honest, I don't know if y'all been exposed to this or not.
It's a sinus.
I don't think we have.
Just a sinus pause.
I was about to say, it looks like the medication that
So,
stops your heart.
when it says pause on the monitor, that's what's happening.
Like literally.
If the monitor is correct, yes. So there's no prolonged PR interval.
I'm beating myself up over here. I'm like, I've labeled all these except that one.
Okay. So let's talk about it. Let's not count our QRS complexes because that'll throw us off.
Just took a little rest.
Took a little rest, yeah. So,
A little rest.
we have a P wave, right?
Mm-hmm.
We have a QRS,
Mm-hmm.
and we have a T wave. All right?
We have none.
Did, exactly. Do we have equal
We have a
space?
scare.
Do we have equal spacing on these three QRS complexes?
Yes.
We do, right? So it's regular on that section. Let's look at our PR interval. Is it normal?
Yes, it's.
It's a little long, but.
So it's a little long, but remember 3 to 5 boxes, right? So the little dots are gonna be considered your box. It's probably 1, 2, 3, 3.5 maybe. So it's in the normal range. Are they getting longer?
No.
No. All right. So it can't be first degree type 1 because that's consistently prolonged PR intervals, right? And it cannot also be second degree type 2 because it's consistent PR intervals. And then we have a P wave and then it drops, a QRS complex. And then it can't be second degree type 1 because I don't have longer drop on that. So I just have normal beating heart and then all of a sudden the heart's like, I'm okay. And so do I have a P wave? Nope.
Don't have anything.
Don't have a QRS complex and I don't have a T wave for this length of time. So I just have a sinus pause.
So what's your treatment, or is it just?
Wake them up.
So things like, of course, like sleep apnea can cause this. There's things like sick sinus syndrome. It's a kind of a rare disorder, I guess. It's more common now, but maybe they had some type of vagal response. So maybe they were real constipated and they were trying to bowel movement. They bear down, so they had some type of sinus pause. Hypoxemia can also cause this. Electrolyte imbalances too. I'm always saying electrolyte imbalances. Those are always important. So let's correct that underlying cause. Sick sinus syndrome. For that, I can put in a pacemaker. So when my heart decides to take a break, it'll fire. That's gonna be kind of that on-demand feature. Maybe my heart doesn't need it for most of the time, but then when it decides that it just doesn't want to beat, then my pacemaker can fire and give it that rhythm that it needs to. That vagal response, man, there's not a whole lot I can do for that vagal response. Maybe they just did it that one time. Now, if they're consistently doing that, then maybe I can put in something like a pacemaker as well, or maybe I can suggest a little more fiber in their diet so they're not having to bear down so much. Or some type of Docalax, stool softener. So treat that underlying cause. Other things to think about, how frequent is this occurring? Maybe I just went through a sinus pause and I didn't even know it. Probably would feel it, I would think. And that's the only one I've had in my entire life. Probably not a big issue. But if I'm having these frequent enough, then I need to do something about it. Maybe I become more and more symptomatic. That's when I need to start seeking out treatment. Questions about sinus pause? Probably wouldn't worry about sinus pause on the exam, just throwing that out there. But I'd love to show you these type of rhythms because you are going to see them at some point in your career.
Oh, that's the one
Yeah, I'm just going down the list. So. All right, I hadn't talked to Natalie yet.
But this is SVT,
This SVT, how do you know?
because the heart rate is 200.
Heart rate's 200, right? So you counted 20 QRS complexes, right? Right. So this is what I was talking about as far as don't get confused with your interpretations. That heart is beating so fast. It's gonna be very hard to tell what's a T wave, what's a P wave. because the heart is beating so much, it's really just kind of getting jumbled up. The heart doesn't have a bunch of time to relax, to beat, to get that full volume of blood so it can pump it out and perfuse those vital organs like we should.
I can tell you exactly how this patient feels.
How's it feel?
Dizzy, like their heart's racing, yeah.
All right, perfect.
And you give them a Denison.
You can give them a Denison, all right? So let's talk about a Denison for a minute. What's our initial dosing of a Denison, Matt?
5 milligrams.
Close.
10, 2.
Going too far.
7.
7. How about 6? How about 6? Adenosine 6 milligrams is going to be our initial dosing. Are we pushing this slow or fast?
Fast.
Slamming it, right? This is not a 3 to 5 minute push. That y'all like to quote me for everything. Not everything's 3 to 5 minutes. So, adenosine 6 milligrams, real fast, right? Am I going to flush afterward?
Yeah.
All right, and I'm going to slam it too, right?
Mm-hmm.
Probably about 20 mLs, because I want that adenosine to get in there quick. All right. Can you push this as a nurse?
Yeah.
Yes, with the doctor.
Is this one that makes your heart stop and restart?
Yes, it does. I wouldn't really say stop, but it just kind of pauses.
But you have to have like a crash cart by the bedside to give it, right?
Yes.
You should.
So as a nurse, I can push this drug. This is my favorite drug to push. I love this drug.
You like going around playing Grim Reaper?
This is one of my favorite drugs
I
to
would
push.
expect.
Because I love watching the heart rate slow down to almost nothing, and then hopefully going back to a normal sinus or something that's a little bit easier to manage.
Would this cause a sinus pause?
Yes, we are pausing that rhythm.
But it would look like that.
So you,
Yeah.
you bypass betas on this and
You're it's bypassing everything. We were cutting all that off, and we were just.
straight to it.
You can give a beta blocker, but usually it's not gonna work for this. Of course, there's an vagal response that we talk about. And then we have adenosine 6 milligrams. So if I push that and it doesn't work, can I give adenosine again?
Yes.
Probably 5 minutes.
5 minutes, maybe a little bit lower than that, so about 2 minutes or so, give or take. How much is my dose gonna be on that? Or 12. So adenosine 6 milligrams, push it, doesn't work. They go right back into this SVT. I can wait 2 minutes, then I can push adenosine 12 milligrams and see if it works then. Can I push a third dose? What do you say?
I said no.
Sam says,
Can we just?
Sam said shock them. Who votes for shocking? Votes for shocking. So adenosine 6 and then adenosine 12. Old school stuff says you can give another dose of 12. New school stuff says 6 and then 12. So you might see it both ways. For our content, it's going to be adenosine 6 and then adenosine 12. After that, we're going to seek out other options. Seek out other help. Our other help is going to be what? Shocking them. Okay. They're going to have a pulse with this, right? So what type of shocking do we need?
Synchronized cardioversion.
Synchronized cardioversion. Good. Not going to be defibrillation, right? We're not just going to go in there and hit the button and see what happens. Got to sync it first. All right. Questions about SVT? Please know how to treat SVT. Okay. So let's review. First things.
Always,
Check your rhythm, assess your patient.
Assess your patient, check your rhythm, good. And then, so we confirmed it's SVT.
get the doctor there.
Get the doctor there, good. Get the crash cart in the room, right? Because if we give them adenosine and then they just stop, we're gonna run ACLS protocol anyway, right? So we definitely need a crash cart in the room just in case. All right. So I push adenosine 6,
And your flush.
then I flush,
And your 12.
and then my 12, flush again,
And then
and then I can synchronize cardioversion if I need to. That's everybody on my list. All right, Josh, what's this rhythm? This one's a tough one. I always have a hard time messing this one up.
Don't really know.
Don't really know. Anybody have any thoughts? Natalie's got a
It's a
thought.
3rd degree complete heart block.
3rd degree complete heart block. Okay, how do you know that?
Because the P's and the Q's are firing, but they're not dancing together. So in other words, P, P, Q, P, 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 Q.
Okay, so your P waves and your QRS complexes are not dancing together. I like that. So your P wave's doing its own thing, so the atrium's doing its own thing. And then your QRS complex or your ventricle is doing its own thing. They're not synced up at all. They're just beating whenever they feel like. We should have the atriums beating first, and then we should have those ventricles beating. And we go back and forth. That's what our normal cardiac cycle does. But with this one, I have a P wave. I have another P wave. Then just another P wave out here. And they just are not synced up with my QRS complexes. QRS complexes are synced up. They're equally spaced. Then our P waves are just firing however they want to. This one could be a very tough one to interpret, kind of as a new grad, even more advanced.
Is there,
P's could be firing, but the QRS is higher than the P.
Exactly. So, definitely gonna get EKG, 12 lead EKG on this one just to confirm what you're talking about. Another key sign or symptom for 30 block is gonna be the bradycardia. Good. So this one's 30 beats per minute here. I've never seen a fast 30-degree AV block. I think Dr. Stokes says she's seen one before. I've never seen one before, but usually they're gonna be bradycardic, less than that 60 beats per minute. I can't give atropine with this. We've already discussed that. Atropine's not gonna do a whole lot of good for us. And what's gonna do good for us? Pacing, right? So that temporary pacer, that transcutaneous pacing, and then I'm gonna get something more permanent to make sure my heart is gonna beat when it should. Questions about that? Jess, what's this? For SODS? Good. Am I running to the patient's room for this?
Yes.
No, yeah, exactly. Or brisk walk. I'm a Harvard brisk walker. Brisk walker. But you are gonna go to the room, right? Check on your patient for this. You're not gonna click off the silence alarm button and then keep eating your biscuit or whatever you're trying to do.
I mean, if you wanna lose your license.
Yeah. So you're gonna run to your room for this. This is a lethal rhythm. Are they gonna have a pulse with this? They should have a pulse with this. Perfect. What kind of things are we gonna do for this patient?
Shot.
Shock. Good. Shock and mag. Any of these VTAC, VFib type rhythms, and torsades is included in this as well. Defibrillation is gonna be kind of your number one priority with those type of rhythms. Early defibrillation is the best chance of survival with this. So we wanna get those pads on early and shock them as quick as we can. So that's kind of our thought. Oh, VTAC, VFib, torsades, let's go in there and let's shock them. I don't have to have an order for that. That's an emergent situation. That's under my scope of practice for my emergency kind of practice orders, if you want to say that. Questions about torsades? All right, Chuck, since you brought this up earlier, what do we got here? Trigemini. This is going to be more of that unifocal approach instead of the multifocal. I can see how it's all kind of in the same shape. Okay. Trigemini, what's that mean for me, Chuck?
Means you're having a PVC every third beat.
Every third beat, all right? So I have a QRS complex, another QRS complex, and then a PVC. So my ventricle's not doing what it's supposed to. So that's the third one. And then another QRS, and then another PVC. So every third heartbeat, every third cycle, I'm throwing that PVC. So if I had a bigemini, then I would have a PVC here. I would have a heartbeat, so a normal QRS complex. And then I would have another PVC. So every other beat for bigeminy. Like we said, there's no such thing as quadgeminy, that's just frequent PVCs. You'll also hear ectopy a lot too. I think one of y'all heard me say that
Yes, I was
last
like,
week.
what are you talking
Sorry, that just kinda came out, cause that's just, but you'll also hear ectopy, some kind of funky beat, some type of PVC, just some type of ugliness. We really just throw that out there a lot. And it can really mean a whole lot of things, but we just say, yeah, they're having a lot of ectopy, so something like a PVC or a PAC. It doesn't really define anything specifically when we use ectopy. Okay. Does this matter?
Yeah.
It does? Okay.
It could turn into VTAC.
It could turn into VTAC, so if we get more and more frequent PVCs, we go into that bigeminy, or we have that sustained run of VTACs, we have 5 beat run of PVCs, then it could mean something a little more, right? So what are we gonna do about it?
In the other room?
In the other room, we could do that, definitely. We could also have a little oxygen on board. Lidocaine is another good option. Let's check those electrolytes, make sure those aren't off. Those types of things. You gotta remember, when we have that PVC, that's definitely gonna hurt our cardiac output. So the more frequent we have those PVCs, the less cardiac output we're gonna have, and our perfusion is gonna be altered. We're thinking about perfusion when we're talking about these. All right, VTAC again. Like I said, number one priority is gonna be to shock, but before even that, how do I know if I need to synchronize cardiovert or just regular defib?
Check the pulse.
Check a pulse first, right? Don't go in the room and start shocking people. All right? Please check a pulse first. Make sure they are alive. Make sure they have a pulse before I start doing interventions. Because if they have a pulse or not, it's really gonna determine 2 different ways that I can go. So please check a pulse first. So pulse, we can synchronize cardiovert with this, so they can have a pulse with VTAC. They have a VTAC with a pulse. Usually it's not gonna sustain for a while. This is usually gonna go VTAC, no pulse, and then you're gonna run that ACLS protocol. Start with compressions, get those defib pads on quickly, shock them, defibrillate them. What's this one?
VFib.
VFib, right? A little finer, a little smaller squiggles than the bigger squiggles, like if you want to say for your VTAC. Assess your patient, and then we're gonna go right into that ACLS protocol with VFib. They're not gonna have a pulse with VFib ever. You don't have VFib with a pulse. So your priority intervention is gonna be start ACLS protocol. That's with your VFib. Please know your VTAC and your VFibs. Last one. Everybody want to guess on this one?
Is that a STEMI?
It's a STEMI. Good. ST elevated myocardial infarction. STEMI. So remember, we were talking about that ST segment. So right after that QRS complex, and then that T wave. So the very end of your ventricular contraction to your ventricular relaxation. That's gonna be that ST segment, so the very end of your QRS complex. Is this ST segment going back down to the isoelectric line?
Yes.
So right here, eventually it is, yes. But for the S wave and then a T wave right here, is it getting back down to this baseline? No. It's up above, right? And then it'll come back down for a P wave, QRS, and then we have another T wave. But we see that it's not getting back down to that isoelectric line right there. So that's that ST elevation that we're talking about. Not getting back down to that baseline isoelectric line. Looks like a fireman's hat. That's what you're gonna hear a lot of the time. Also, people refer to it as a tombstone. If you don't do intervention quickly, they'll have a tombstone. So, fireman's hat, tombstone, however you want to put it for there. Bless you. What kind of things are we gonna do for this?
An ECG in 10 minutes.
ECG in 10 minutes. Okay. What else? Aspirin, morphine, oxygen. Okay. Good. She did. She did.
Please tell her to put this on too. We know this.
She's got questions in there. I'll have to look and see which ones she put in there. Okay. And then what else? They got her medications. Where are they gonna go? Cath lab? All right.
Cath lab.
How long? I heard 90 minutes.
Yes, they're ready to.
We gotta balloon them out, right? We got to
Unless you're-
stent open that artery, that coronary artery that's causing this issue.
Unless you don't have a cath lab.
And longer than 9 minutes, you give the
The
Fibrolytics.
fibrinolytics.
TPA.
Clot,
If they
clot
can.
busters. If they can get it, right?
There's a whole list of things they can't get for.
So hemorrhaging, hemorrhagic stroke, recent surgeries, trauma. Those lines can be a little bit grave though. So who knows? That could be, if they had a recent surgery, how long has it been? What type of surgery? If they don't get this TPA, this fibrolytic, are they gonna die? Can I control my bleeding enough? Or can I get them to another cath lab, to a different hospital? Those questions. Questions about rhythms? Got a good idea of that?
Yes.
Okay. Let's take 5 minutes and come back.